Well, thank you, John, and thank you all. Hang on right now. And I'm going to, can you hear me? Because they gave me this, and I don't know whether it's any better or not, but let me start off with one little bit of housekeeping that is not any part of the script. But if you drive a Nissan Altima CVT 9831, sneak out. Because the way you've parked is really keeping it weird for Austin traffic. It's parked in the northeast corner of the parking lot, and you obviously were so excited about getting in here that you didn't pull into the slot, and now people can't get around you. So, nobody look. In fact, everybody just close your eyes. We'll do this like in the third grade. Whoever took it, go take it back. I couldn't be any, as you can tell, I'm pretty excited about being here today. We're going to have, I get to participate in two panels, and the first one we're going to talk a little bit more about what was just kind of laid out for you, which is the integrated delivery system and the community care collaborative and how that plays out. And that's going to fold then into how another panel where we will talk a little bit about the innovation zone and how we see all that sort of growing out of what is happening with the integrated delivery system, the medical school, teaching hospital, and that sort of thing. So it's my pleasure to get to be here. And I get to introduce this panel, and I'm going to give them just brief introductions so that we can actually get into the meat of questions. The protocol that we're going to follow, you notice I used a medical term there, the protocol, because I'm really into this stuff. The protocol we're going to follow is I've got some questions, and I'm going to get us started. But you can ask questions as well. And Linda, make sure I say this right, but you can, Linda, yes. They're going to have cards, right?
You've got cards in their packets.
You've got cards in your packets. And if you want to fill out a card, pass it toward the end, and we'll have somebody pick it up, and that way we'll come up and we'll make sure that I'm asking good questions because I will be asking your questions. So feel free to do that as we go along. I'm pleased to be joined up here on the stage by Dr. Mark Hernandez, who is the Chief Medical Officer of the Community Care Collaborative. Next to him is George Miller, the Chief Executive Officer of Community Care. At the far end there is Dr. Clay Johnston, the Dean of the Dell Medical School. And last but not least, Debra Hernandez, who's the Vice President and the Chief Operating Officer and Chief Nursing Officer for University Medical Center, Brackenridge. So let's give them a round of applause as we start this. We're going to move pretty fast because there are a lot of questions. I've told you about the cards. They will, as they answer questions, obviously they're going to try to keep things short and sweet. I will help with that if need be because I am the embodiment of short and sweet. And that wasn't expected to get a laugh. I'm a little disappointed in all of you. But feel free, if you hear something that prompts you to have an additional question, use those cards because we want to make sure we're answering your questions. I'm going to start off with the Dean. Dean, I've now been on a number of panels and stages with you, and I've heard you speak several times about healthy or health ecosystems. Why don't you kind of define that for us? And I hope that's not me ringing, but I don't think it is. Yeah.
So you have a tendency to think about med school just focusing on health care, the hospitals and the clinics and how they are, their roles in health. But in fact, that should be the thing that we're trying to reduce in our communities, right? We don't want more hospital beds. We don't want more clinics. We don't want to need them. What we want is to be taking care of people while they're still healthy and keeping them healthier for longer. And this isn't an issue for the med school to solve, at least not by itself. It should have a key role, but it should be about enabling others in the community to do a better job, to step forward, to all participate in bringing the whole ecosystem forward. So that means if you've got somebody with a clever idea, allowing them to vet that idea, and then providing the support to test whether that idea can actually work and be scaled. And then if it is, accepting that as then part of the way in which health is promoted or care is delivered in your community. So that's our vision for how we want to work in this city. It's totally different from the way the Texas Medical Center works, where and I call that this fortress model of healthcare. You build these fortresses, and everything's either in or out of that fortress, and they only take care of the stuff that's inside the fortress. That's not what we think makes sense for Austin.
Great. Well, let me follow up on the heels of that, and Dr. Hernandez, Mark, let me ask you, as part of what the dean just laid out and the role that you play with the collaborative, why don't you, and I get a lot of questions about this, by the way, out in the community. Describe in a little more detail what the integrated healthcare delivery model is that the CCC is working to accomplish, and kind of talk a little bit more about what the CCC really is.
Okay. Yeah, let me do that. And I'm going to talk about 3 different things. I'm going to do it quick because I know he's going to hold me to being quick. So first off, I could just give you a definition of an integrated delivery system, and that's basically a network of organizations and healthcare delivery entities that come together and take the fiscal and clinical accountability for a defined population. So we say we're going to take care of these folks. We're responsible for them. We're responsible both for the quality of the care that's provided to them, and we're also responsible for the use of resources. And we take that responsibility. A more structural definition of what the integrated delivery system is probably resonates better with most of you, which is to think about, some of you probably have seen your doctor recently. Some of you have probably seen your dentist recently. Some of you may have needed to go take a family member to an urgent care, or you had somebody in your family need to go to an emergency room. And we think of all of these sorts of services as being separate of each other. And yet, frankly, they shouldn't be. They're all related to healthcare. And in fact, there's a whole bunch of other things that are related to healthcare as well. So the ability to get transportation back and forth to healthcare really should be part of the conversation of healthcare. The ability to get other social needs met. We find that individuals with depression, for example, do worse with their chronic illnesses. Why? Because we don't do a good job of managing their depression, and most chronic illnesses are diseases of self-management. Those people need to be able to take care of their own issues. So an integrated delivery system takes all of those things into account. It doesn't say that when you go see the medical doctor that I only take care of the medical issues and I don't have anything to do with the rest of that. If you need something else, I send you somewhere else. And so an integrated delivery system often brings those things under one roof, but even if they're not under one roof, they're connected wherever they are. And where we deliver services could vary from an office to at your local pharmacy when you stick your arm through the little thing that takes your blood pressure while you're waiting on filling your meds. That should be connected to the system. That blood pressure should not be just known to you, but it should be known to your doctor as well. Otherwise, why'd we take it? And maybe your home. Maybe that becomes a venue of care for you, and that's somewhere where we're providing care to you. But let me sum it up this way. Healthcare is complicated, and unfortunately, I believe it's always going to be complicated. So I wish I could tell you that we're going to design a very simple system, but we're not. How many of you are still part of the contingent of people that wear a mechanical wristwatch as opposed to a digital? All right, yay for you people. I still wear a mechanical wristwatch. How many of you could take it apart and put it back together?
Good analogy.
Nobody knows how this works. It's like magic. Unless you're a watchmaker, you come from Switzerland, you don't know how this thing works, but you use it every day, and it reliably tells you what time it is every day. And you only needed a smidge of training to be able to use this mechanism. Our healthcare delivery system needs to be similar. You don't have to understand the workings of this, that's our job to do, but you should, with a small amount of instruction and with help, anytime you need it, be able to utilize this thing we call healthcare. And it should travel around with you just like this wristwatch does. and it should always be there to help assist you in optimizing your health. That's what an integrated delivery system is.
So, a new model, new approaches, and Debra, why don't you tell us a little bit how it is that we're going about building this wristwatch he talks about? How are we building the model? How are we developing that?
I think I have to use this a little bit better.
All right, go for it.
I think that as we look at the new hospital and the way it's being built, it really did surprise me when I first came to hear that the hospital was going to have fewer beds. And as I have really gone through discussions with not only Dr. Hernandez but other people, I have learned that this is our opportunity to really transform it because we're not going to be able to replicate it. I know from a hospital perspective, we're looking at, what do the rooms look like? How can we make the rooms larger so that the family can actually be a part of the care that we provide to our patients? Another piece of it is, how do we make sure that we're taking full advantage of technology to do things differently, to provide fewer steps in getting things done? Most recently, as this week, we at University Medical Center Brackenridge have started on a journey of performance improvement in the way we deliver our care at the bedside. We've launched what is known in the industry as lean methodology for performance improvement. We had the opportunity to bring a lot of our frontline staff, physicians, residents, healthcare leaders, and even patients and their families into the process to say, what is it you want from us as we provide care? We're taking all of that and taking it back to our construction and design teams and letting them know how to help us get there. So we're looking at this from a patient-centered perspective, and it will go beyond the walls of the hospital, but I am most informed about what is going on in the hospital at this point in time.
Great. George, help us out. Who, and we got and I'm going to add one of the questions we've already gotten from the audience, but who are and who will be the potential participants in this program? And also, I want you to talk about the beneficiaries, but let's start with the participants. And one of the questions I got was related to psychiatric care, behavioral health. Which community partners would we be planning to use to provide that critical service? And then, as just part of it, I'd like for you to also touch on this long question. I apologize for that, but how does this play into the mission of Central Health to create and improve care for low-income residents of Travis County? Because we've got partners that we've already talked about: a new medical school, a new teaching hospital, creation of a community care collaborative. How do those participants and others, including behavioral health, how does that play out and serve the mission of this important body, Central Health?
Very good question. I appreciate you asking, and so I would expect you would let me give a long answer since it was a long question.
We'll negotiate maybe.
Yeah.
Go ahead.
Yeah, let me see if I can unpack all of that and answer the question. First of all, as far as the mission is concerned, we're very fortunate in this community to have Central Health and have your vision, and through Central Health, we are one of the players, but all of the players in the community have come together in a unique way. I've been in healthcare about 30 years. I've never seen the interplay between, in this community we have 4 FQHCs, Gwen, Peoples, Lone Star, and Community Care. Then we partner with the UT School of Medicine, with also our partners with Seton and St. David's. We all come together under the Community Care Collaborative, and we are really trying to redesign and transform healthcare in a very, very unique way. One of the ways that is very, very unique is that in that transformation, we are putting the patient at the center of healthcare delivery. When I first came here, I heard Dr. Mark Hernandez talk about the fact that a patient should get the same level of care, whether they live under a bridge or they wear a suit, and get care delivered in such a holistic way. It does not make a difference. we're building a better model. And part of the model we're embracing, and our Chief Medical Officer, Dr. Debra Morris-Harris, talks about team health and team care, so that with that patient being the center, that we have everybody working at the height of their license, and that means that that patient gets as a partner with their health, is the physician, a PA, nurse practitioner, a nurse, an RN, LVN, a MAC, a pharmacist, a psychiatrist, a psychologist, and a dietitian and a nutritionist to deal with the entire care. One of our partners also is ATCIC for the behavioral part, and we have integrated.
But that's very important. Let me pause.
Sure.
Don't run past that. Talk about that a little bit and the role that they play.
Yes, so I get more time now. Yeah.
But this may be the last time you get asked a question. So, you probably ought to take advantage of it.
Yeah, I will. Well, ATCIC is the integrated delivery health system for behavioral health in Travis County, and we're very fortunate we partner with them. They are in 12 of our community care clinics, and we partner with them in 4 of theirs, so that we provide one-stop healthcare delivery system for that patient. If they have diabetes and they have behavioral health services, we can provide comprehensive transformative care with them. And one of the other things about transformation healthcare is that we then ask the patient what their needs are, and depending on their culture and its cultural competency, we make sure that we provide what's best for them. Instead of telling them what's best for them, we ask them and have them participate, because as Mark said earlier, we want to prevent people from using hospitals and clinics if we better educate. And that's part of that problem of transformation of healthcare, to teach and help educate that patient. And that's why we put this whole team wrap around them in care.
Thank you.
Well.
I'm gonna go with you, Dean. As part of the question we got related to psychiatric and behavioral health, why don't you talk briefly about what you just announced in the past couple of weeks?
Sure.
Related to that, because that also plays a role. And George was at that announcement. And
Yes.
it's an important
Right.
part, and it involves ATCIC. And so, why don't you talk a little bit about that?
Yeah, well, mental health is a huge issue, not just in Austin, but all over the country. And it's not, although it impacts everyone, in fact, access to mental health services across the city is a problem. But it particularly impacts lower income and minority populations. That's true here, that's true everywhere. It was true in San Francisco. So we know that the current programs that we offer are not doing the trick, and we have to come up with culturally sensitive, matched types of programs. And so we've been working on, and we just announced a partnership with Houston Tillotson to work with them to start to address health disparities as an important issue, particularly in mental health. We've had the help of the chair of psychiatry from Howard helping us to design this, and we hope to get more help from him in the future. And we'll build specific programs that are culturally sensitive, and also use that as a training platform, bring more people into these issues so that we have more practitioners on the ground.
Debra, talk a little bit about, this question had multiple parts to it, and that's why I want to make sure we're trying to answer all of it. But part of the question also referred to a psychiatric emergency department. And of course, that's been something a lot of us have been concerned about and working very hard on for a long time. And Central Health, through the 1115 transformation waiver, one of the DSRIP projects involved an emergency department. Talk a little bit about that, and talk about where you see that going with the new teaching hospital.
Okay. Yes, just this past year, I think it was around March or April, we opened the Seton Psychiatric Emergency Department at the University Medical Center campus. And we have seen all of our numbers of projections beat every month. Every time that we thought we had it right on our volume projections, we have really surpassed those projections on the number of people that we're seeing in our Psych ED. The beauty of the Psych ED is that we're not having to keep people with behavioral health issues in our mainstream ED, what I call our acute care space. If we can get them medically cleared, we're bringing them into the psych ED, and they're able to really get better in a therapeutic environment. For example, sometimes in a regular ED, for lack of a better term, we would like to have our patients in one space. We don't want them roaming around in the ED because there's so many different people coming in with different disease processes. In our psych ED, we actually can encourage them to walk around because it's a quieter space, and it helps them get better through their acute phase, so we can determine where to place them long term. As far as the psych ED of the future, I am not aware at this time that there has been a formal plan about what that looks like.
So that's one of the areas that we need to focus on as we look forward. And I'm gonna come back to, but Dean, I want to come back as we have talked, we've looked at different things like how do you make Austin a center for comprehensive cancer care? How do we deal with behavioral health in the future? And we're going to talk a little bit more about the use of properties, but is there a thought process for what we jump off from this foundation that we've created where we might be on behavioral health in the future? And then I want to come back to the two of you all with the same question.
Is there a thought process?
Well, for example, could we envision in the future having a psychiatric hospital? Could we that would be part of the medical school process and address some of the
Yeah, absolutely.
the gaps?
Yeah. So our current combination, and we have some very good psychiatric hospitals. Shoal Creek's been around for a long time. We have 2 new privates. That still doesn't give us enough capacity. And so we do need to think about it, but we're going to also have to change the model for psychiatric hospitalization. So right now it's very expensive and it's not reimbursed for its cost. So there are 2 problems there that haven't been addressed: the actual cost of delivering that care, and can we make it, can we fit it better with the needs of people? And the other is recognizing that mental health is such an important condition. We have to adequately reimburse for it so that we can support the facilities that we create. So absolutely, that's part of this transformation. We have to actually align the finances with society's benefit, the needs for society. We don't have that in the current healthcare system. It's too procedure focused, it's too doctor focused, it's too hospital focused. It's got to be more about getting the monies to flow to the things that society really values. That's true in psychiatric care as well. One of the things that we do, or that we don't do, is we don't keep people who we know have serious psychiatric illness, we don't keep them well outside of our facilities. That's ridiculous. It's unbelievably expensive to just send that homeless schizophrenic back onto the street. And that's what we do. We looked at this in San Francisco, the mortality rates too for these folks, it's like 10% a year. Why do we tolerate that? We don't do that. We don't tolerate those sorts of mortality rates for any other health condition, and yet we do. And then it's not that we do that to save us money. Those are actually the most expensive people in our healthcare system, because when they come back in, they're so sick and they require hospitalization. So that's an example of how we, as maybe boring as it sounds, it's very, very important to take that step back and say, okay, there's a person. Let's be person-centered. There's also a societal perspective, not the hospital perspective, the insurance company's perspective, the doctor's perspective. Let's match up the societal perspective and the person's perspective and find the best solution for both of us.
Well, I want to go to Mark and have him say something. I've got a specific question for him in addition, but that's one of the things that I just would point out, that remember that it was November of 2012, just a little over 2 years ago, that the election occurred. And sometimes we play the typical Austin game, which was, yeah, that was 2 years. Why aren't we done? There was a reason, by the way, a year before I said 10 goals in 10 years, because we're not going to solve everything immediately, but you're already hearing on this very important area about how the thought process is working, and even that we now have a psych ED now and for now, which, by the way, the success of that, I think, will push where we go. I mean, we're trying these new things. So that's a very important thing, is enormous progress being made, setting the foundation for future progress. And so, Mark, I want to come to you and ask you to respond to that, but I also want you to elaborate in your answer a little bit about what you said in your initial comment, which is, as Central Health funds some of the needs that for the population that it funds, and we're the DISRIP project with the new ED, the psychiatric ED, those kinds of things. You made a comment about there being overlapping health problems when you had behavioral health issues. Talk a little bit more about that, because I'm not sure everybody always knows what that means.
Yeah, so that's a great clarification. And just to build a little bit on what Clay was talking about, I think so it's wonderful we have a psychiatric ED now. It's also, I'll just from my personal perspective, the fact that we're beating the volume targets every month is horrible. It's horrible. So if we didn't have regular emergency departments, if we closed them all today, then what we would say is that's horrible for the population in Travis County who has a car accident today and needs a trauma center. And that's true. I couldn't anticipate I was going to have a car accident today, and when I do, I need a trauma center. The problem is in the regular emergency departments, we see a lot of people who have chronic problems like lung disease, heart disease, and because we aren't able to manage them well in the outpatient setting, they get worse and worse and worse until they need the emergency department. Well, guess what? It's the same thing for psychiatric care. Yeah. There are some individuals who have a psychiatric emergency, and the right thing to do for those folks is to have a psychiatric emergency department. And we should be proud of ourselves that this community put one of those in play. Having said that, we see a lot of people in the psychiatric emergency department who have existent behavioral health problems that we don't stabilize while they're in the community, so they get worse and worse and worse and worse and worse until they show up in the psychiatric emergency department and help us build these high volumes. And what that really says is we're not managing people's psychiatric issues as well as we could in the outpatient environment, such that they're needing the emergency department to save them. And that's a problem. So frankly, I would like to see in the future that we don't need as much reliance on the psychiatric emergency department. I'm not saying we don't need one. We're always probably going to need that capability in play, but I hope we're not building bigger and bigger ones as we go forward, because if we do, we're kind of missing the boat. Yeah. One of the things that came from this question early on, and I think trying to answer what Kirk is asking about, is the notion that I don't see behavioral health problems, and I know my colleagues up here agree, as being fundamentally different in some way from the other medical problems that we try to solve of people. And the comment that, we have 10% mortality rates. By the way, those people are not dying from suicide. Yeah. Those people are dying from heart disease, lung disease, and all the other things that kill all of us, cancer, et cetera. They're just doing it faster. Right. And they're doing it faster because their mental health issues prevent them from getting the medical care that they need. So guess what? We're not going to solve this problem well until we get to a point where when care is delivered, it is comprehensive towards all the needs of the patient in front of you. So it has to look at both what your medical need is, but it has to look at what your behavioral health need is and what your social need is. And if you got a bad tooth, we ought to be able to take care of that as well. And it's going to have to be much more comprehensive at the point of care than it is today if we really want to see a change in outcomes later on.
George?
Yeah, if I could just add that one thing that we're trying to do as a first step to that solution, through Central Health 1115 waiver, we have 3 mobile teams, such that if a patient can't get to us, we go out to them. Those mobile teams are going around Travis County and delivering care, and we're very excited and very successful. It has been successful because of 1115 waiver through Central Health. One of the other things that we're getting ready to begin is street medicine. We're going to put backpacks on our physicians and our nurses and go out under the bridges into the Runberg communities and others to find those patients and then transition to the established facilities that are in our community and try to work. That's only one step in the bigger problem that both Clay and Mark just illuminated. But that's the first step, and we're very pleased about that first step.
Can you talk a little bit, and I hope this, before I came in, this wasn't something covered, and I'm being redundant here, but in the role that you play, a lot of people, maybe some people in this room for the first time heard community care. And they may have heard for the first time your name as part of community care and as part of this community care collaborative and the integrated delivery system. Can you talk briefly about how you're funded and what that means in the context of uniquely Austin clinics?
Sure. There are two parts to that. One, we are an FQHC, federally qualified health clinic. We're very pleased in this community. There are 4 of us who carry that title. El Buen, Peoples, and Lone Star, and then community care. But what makes community care a little bit unique, and one of the reasons I chose to come to this community is that we are funded also by Central Health, now the CCC, and they're our co-applicants. Central Health are our co-applicants. And because of that, we happen to be very, very large. We're one of the largest FQHC in America. We're probably the 10th largest, and we're the largest in the state of Texas. We have 25 locations, and we provide comprehensive healthcare services. My term is, I like to say, from the womb to the tomb. We take care of prenatal care, high-risk OB, pediatrics. We have dental, we have psychiatric services. We have probably the best HIV clinic in America, our David Powell Clinic, bar none. Its outcomes is absolutely outstanding. We're very passionate about taking care of patients. This year we'll see well over 308,000 patients. We have 700 team members, and about 150 of them are providers. And we provide, again, comprehensive healthcare services, including specialty care. One of the specialty care clinics funded by the district projects through Central Health was a Hep C clinic. And we have cured hepatitis C in 18 patients, and a third of them were homeless patients who kept their appointments, and we were able to provide outstanding care. So we're very pleased to be a part of that.
And I'm just going to underline what he just said. Think about that, and a big part of that was when the vote. That's right. Tax dollars. You knew where I was headed. Was tax dollars through Central Health helping fund those clinics, and tax dollars where the voters in this wonderful community we live in increased their tax dollars, thus increasing the opportunity for those kinds of things through Central Health, making those sorts of payments. So that's very helpful.
Yeah, and that's why I came to this community, so thank you.
Yeah. Well, we're glad to have you. Let's go to a little bit more about the integrated delivery system. We've got a question from the audience about the plan for post-acute care. And I'll read the question. What is the integrated delivery system plan for, quote, post-acute care, i.e. skilled nursing, rehab, long-term care, palliative and hospice care, that sort of thing? And is there a possibility of using the campus in some way to help with some of that? And so Mark, good. Yeah, please.
So real quick, just in the conceptual model that we have of the integrated delivery system, we kind of divided it structurally into 2 kind of groups. There are service lines and there are integrators. And service lines are those things that actually provide groups of like services to individuals. So examples of service lines, I may even try to get all 8 of them, is primary care. And inside of primary care is primary care medical, primary care dental, primary care behavioral health. There's not a separate carve out for those things. They live inside of that. Specialty care, and again, it's specialty across all of those disciplines. Urgent emergent care, inpatient care, specialty care, or I already said that, pharmacy, excuse me. And then health promotion. How do you provide services to people who are already healthy? Guess what? That's something we don't really do all that well, but we're going to have to do that if we want to transform the health trajectory of our community, because we have to have relevance for people who are already healthy. So we need to figure out ways to be involved in that space, And then the last two are palliative care and post-acute care. And what I would tell you right now is that the state of those particular service lines for the uninsured and underinsured are very thin in terms of what we provide in those two service lines. So what I would say is that in the integrated delivery system, for us to become fully integrated, we will have to have palliative care services, and that's both primary palliative care. How do I deal with your symptoms? Palliative care is not just for people who are terminal. I think that's a common misconception. Palliative care is not just for people who are dying, though it is for people who are terminal, but it is also for people who have chronic illness and who suffer from symptoms as a result of that. And primary palliative care is that palliative care that's provided by primary care. So we need to do a better job at the primary care level providing palliation to individuals who need it. Specialty palliative care is when we employ specialized physicians and nurses who have special expertise in that area to provide palliation when we can't get control of symptoms at the primary care level. We need to build those capabilities into our system, and I'm sure I'm hopefully going to be working with Dean Johnston as the medical school becomes more fully fleshed out to bring those services online. Post-acute services, so the notion of rehabilitation, home care, all of those issues. These are very crucial services because this is how we deal with them today. If you need those services and we don't have them for you, you stay in the hospital. That's how we deal with it. Right. We keep you in the hospital for additional days, provide those services in the hospital less effectively because the hospital is not set up to provide those sorts of services. It is an acute care facility. So we're using the most expensive part of the system in a poor way to provide services to individuals that do not get as much bang for your buck, and then ultimately those people get discharged to their homes, where because we have not put the right services into play, the chances that they don't get a full recovery and come back and have more sickness and end up back in the system are higher. And so this is something we have to do. Now, the question would be in this particular forum is, could we use the old building to do that? I don't know. That's a bigger question that I don't want to talk about. Do we need the services? We need the services. And we're going to have to build a model that has the services, whether it's we buy the services, whether it's we provide the services. I think that's a food for thought conversation, but there's not a question about whether we need them. That's a given. We will have to build that service line in order to get the integrated delivery system fully operational.
You want to add something, Dean? Because I have a question for you as a follow-up, but go ahead.
Okay, well, just real quickly, too. Fundamentally, again, we have undervalued all of that stuff. Except for the doctor visit and the procedures, we undervalue pretty much everything else in the healthcare system. Part of the solution has to be taking a step back and asking, how do we knit all this stuff together and show that it being knitted together is much more valuable than paying for the little pieces and failing to pay for critical pieces.
Well, and and this is a question that comes from the audience in part. So I want to, what you just said as a follow-up is, and I'm gonna read the question specifically and put it to you first. But Debra, I think you have some past experience that you can also address this. What statistical evidence is available or being developed which demonstrates that the investments in proactive IDS type services will ultimately cost our community less than current pay per procedure system? Tax dollars, the writer puts tax dollars, lost days of labor, lower insurance costs, that sort of thing.
Right. Well, actually, there are a number of examples of where pieces of this have been done. It's never been done at a community-wide basis, other than if you take the UK, right? If you look at the British system, it's much more integrated and thoughtful and designed around society's needs. That's not the way it's sold to us here in the US, but if you look at it actually, if you look at its ratings overall, and the WHO goes out and rates things, it rates number one of 11 developed countries, and we rate 11th.
Right.
They pay $3,500 per person, and we pay over $8,000.
Right.
So on a country level, that's an example. Within the U.S., there are some integrated delivery systems that actually have worked pretty well, although I think they've underperformed. Kaiser Permanente is a common example. And in fact, Kaiser has dramatically reduced mortality rates for cardiovascular disease. They took it on as a target, dramatically reduced it by treating hypertension in much more creative ways, treating diabetes, getting people on statins. So those are two examples. We're not going to just jump to either of those systems, clearly. So we have to, it's going to be a uniquely Austin solution to this problem. But there are ways to get us there, and I'm going to keep my answers brief, but I'll just say there are ways to get us there by incrementally dealing with, for example, common problems where we know we can stitch this stuff together and do a better job and also lower cost.
Great.
And let me, for one thing,
please.
let me just say, why it's lowering cost isn't just about making it cheaper. It's an access issue.
Right.
We cannot pay more, expect society to pay more dollars for healthcare. So if we want better healthcare, we sure as hell better eliminate the inefficiencies and the waste in our system so that we can have the better healthcare that we want. So it's not just about making it cheaper for our employers. It really is a societal need.
Deborah, you want to add something to that?
Yeah, I think the only thing that I would add to that, and I've had this dilemma throughout my career in healthcare management, I think that the way our system is currently set up, we as a hospital provider are paid differently than the people that provide those services, such as our physicians.
Right.
So once we can align what our reimbursement models look like and look more at value-added care and what we pay for outcomes instead of services, we'll get to the best answer quicker. I don't know that it's been done right yet.
Yeah.
And I think this is our opportunity to take it to that next level and really align how our providers get paid based on value that they bring to patients.
George, go ahead.
Let me just add to Clay's mathematics. In this country, we spend $2.7 trillion on healthcare each and every year. That's the $8,000 per man, woman, and child. But yet, according to the World Health Organization, based on our outcomes, we're 33rd. 33rd. Let me give you 3 quick examples of that. Statistically, in the United States, we should only have 8 to 10% C-sections by women. Factually, 1 out of 3 women have a C-section in America. 1 out of 3. I have 3 children. The first one was a C-section. Factually, 1 out of 3. And I'm amongst physicians and other providers. I probably shouldn't be using these statistics, but
So,
but
real.
There's no cure for low back pain. No cure. There is no cure for low back pain, but there are CTs and MRIs and a lot of drugs being given. There's no cure for migraine headaches. No cure. But there will be myelograms, CTs, and MRIs and a lot of drugs. The best prognosis, and I'm not a physician, is you go in a dark room and turn out the light and take a pill. That's the problem with the American healthcare system. We got to change that model, and that's what we're doing here today.
I'm going to dispute a little bit of that. If I can get through this legislative session, I know that it will cure a pain I'm having. Just saying. Don't mean to get in a fight with my panelists, but I think there's a cure. Just saying. Just saying. But I want to emphasize, part of what is answering that question, of course, is that you can point to statistics. I mean, we know that there are statistics about keeping people healthier and having a physician or health care home makes a difference. But what I hear you saying is that we really are on the cutting edge here in Central Texas with the Community Care Collaborative, with what Central Health is doing, using a medical school as a hub on trying to achieve those. So Dean, I want to come back to you and ask about the medical school as the hub for that. And I'd like for you to update us, if you will, on where we are in terms of the residency programs, when we will have medical students, and how you see them working in conjunction with Central Health as part of Central Health's mission to provide healthcare services in the community.
You bet, yeah, yeah. So first of all, we don't really see ourselves as a hub. So we see ourselves as one of the conveners that brings partners together, sitting around a round table, and maybe we pay for the lunch, I don't know. But, we're
Somebody write that down.
Yes. So we want to encourage the partnerships and enable everyone around that table. So then one of the key things that we provide, that we should be providing, is expertise, right? So where we know that good ideas and guidance are going to come from academia, hopefully. So how do we collect really smart people at the cutting edge in population health and health economics and in person-centered care here as a resource for the community to enable the community where we hope many of the ideas come from for solutions. So that's one piece. Then the specific pieces you asked about. So the residents. So we already have 262 residents here in Austin. They've been UT Southwestern residents. Before that, they were UTMB residents. They're good, actually, in that residents are after med school. You do your residency in whatever specialty you have, and then when you're done with that, you can become a doctor. They're already doctors, but they're not licensed to practice independently. Those are now our residents. So they came over, they're UT Austin residents. We got accredited to bring them over on January 1 of this year. And we manage them with Seton, and actually right now, because historically Seton's paid all their paychecks, that's the way that happens, but we're the overseeing academic partner in that relationship. We're going to change those residencies some, and we're working with Seton on it. The residents and medical students need to reflect where we see medicine going, not the way it historically has been. And then the medical school, so we had our accreditation visit, and it went really well. That was just about a month ago. We will hear finally about our accreditation in June. If that goes well, we'll have students here the following summer, so 2016 summer, year and a half, we'll have our first class here. 50 students in that first year. So both need to be, both residents, students, and also practicing physicians need to be ready for this future. So our educational programs have to align with what that looks like.
And are you making changes in the curriculum? Not changes, it's a new curriculum.
Brand new curriculum.
But is your brand new curriculum somewhat different than what we might see in other
Oh, it's
places?
really different. Yeah, yeah. So it's completely
Unique.
weird.
It is unique.
It is the weird word.
I like that. I'm not sure I want my doctor to say he's giving me weird health care, but talk about that just briefly, and then,
If it's better.
yeah, no,
Yeah, so it's no crystals or that kind of thing. But
Not yet.
it is so facts today are cheap. It used to be when I went to med school, they just pour all these facts in your head, and that's what you were supposed to take away from med school. Memory is very unreliable. Most of those facts are not useful, and our resources, like our cell phones, are much, much better. So physicians can access information they need much more readily than they used to before. So that allows us to compress that cramming stuff that isn't really effective in education from 2 years into 1 year. Then we get them into the clinic sooner, and then we have an innovation and leadership year where they focus on the future of healthcare, basically. Population health is one big track for that. They'll be working on the kinds of projects we've been starting on to discuss today, and healthcare redesign is another track, and again, the other series of projects. And then the third track is research, and then they go back and do their subspecialty training or additional project work. In addition to that, throughout this, they're learning about much more about population health. How do we keep people healthier? Much more about nutrition than ever before. Much more about communication skills. So it's designed more about what we think the modern doc ought to look like. And no, there are no other curricula that look like that.
that's pretty exciting. Tell me, one of the questions we've gotten, and I hear from time to time, is talk about primary care physicians and the training there.
Yeah, real important. So I got to say that we have a big problem in primary care. It doesn't matter whether we say, okay, we're going to increase the number of slots. if primary care isn't more attractive as a specialty, they'll just do something else. So right now, primary care is not attractive as a specialty. So the fundamental problem is how we make it a much better career choice. So we're working on that. These guys are going to be great partners in how we do that, but we think the primary care doc is really the perfect leader in defining how better to deliver care. So we should enable them to actually be our leaders in healthcare redesign and population health, and give them more tools in which to do that. Taking care of a whole panel of patients in their hypertension, not a 9-minute visit for hypertension, which is pretty average and totally dehumanizing for the patient and the doc. So that's one key part. So that's an upstream issue. Then, yes, we have to think about how we then make it more attractive to students during their training. So our students are going to spend a lot more time doing primary care. They're going to go into community care's clinics, they'll go into people's, and they'll be getting more of those exposures. They'll all have some community-based project as well, and we hope that that excites them about working in the community. And then upstream from that, we have to have our students looking like our communities, and they're not right now. So some of that is just encouragement, saying, gosh, this is a career option for you, but you need to do this if you want it to be a career option. But that means pipeline programs back into probably middle school. If you're not on track to go to med school by middle school, you'll never get back on track. The pre-med stuff's easy. We got plenty of pre-meds, but we've got to get the pipeline going into pre-meds looking different. So we're working with AISD on those programs right now. We're going to start with some summer camps this year. We haven't announced it yet, but I'm announcing it.
I believe you just did.
They tell me to be quiet about these things until the official announcement. My communication guys are back there, but I never can keep a secret. But then we hope to roll that into even more comprehensive programs over time.
Can I stick one
In fact,
thing?
I was going to come next to you because I want you to stick whatever it is that you're thinking about doing, but I want you to add, from the standpoint of the community care collaborative and the role that Central Health plays in that, I want you to make big, if this wasn't what you want to stick in there, how you see what he just said about the med students and the residents actually providing those services in a different way so that we have a unique medical school in our community that's providing services consistent with the role of Central Health.
Yeah, so I love listening to Clay talk. Hope you guys do too, but everything he says really resonates with me as we're trying to design better care delivery in the environment. One thing I would say is that there is this thing we talk about in medical education, it probably exists in other sorts of education as well, known as hidden curriculum. And the hidden curriculum is that curriculum that's never written down, but it nonetheless is transmitted to learners. And it's usually transmitted to learners by their experiences, both their experiences of being with the teachers and the experience of the learning environment. And one of the things that I think is key is that if we have invested in creating a very novel, very unique way of training physicians for the future, but we put them into a care delivery system that is rooted in the past, that's the hidden curriculum.
Right.
And the hidden curriculum is we have physicians, primary care physicians, who are unhappy with the work they're doing because they're mired in a system that doesn't work really well for them or for the patients, and they can't help but show that. And we'll put learners into that circumstance, and the learners will quickly pick up on the hidden curriculum, which is, I don't want to do this for a living. So you put me here because you tell me I got to get my grade in this class, so I'm here and I'm going to do it, and then I'm going to go be an orthopedic surgeon. And that is of no help to us going forward if we're going to build this on the backs of primary care, which I believe we will and should. And so one of the things that's key for the collaborative across all of the member organizations of the collaborative, all of the service partners that we have that exist inside of it is we have to go to each one of those service partners and create a new culture for the way that we deliver healthcare. So, somewhere in a lot of this conversation that we've had, we've talked about the notion of how do you go about what is an integrated delivery system, how do you build it? And I could bore you for the next 2 or 3 hours with a lot of the mundane, here's how you go about building an integrated delivery system. But I will tell you that fundamentally, the biggest piece of building the integrated delivery system in Travis County is culture. There has to be a belief that inside this organization known as the CCC, this integrated delivery system that we're building, that we're all one organization serving the patients. And it doesn't mean that our name tags are changing, they're not. Okay, so I wear a name tag that says I work for Seton. George wears a name tag that says he works for CommUnityCare. Clay wears one that says he works for the University of Texas. And there's a whole bunch of other partners in the room who wear their different name tags, and that's fine. But when we're serving these patients, the commonality is we're all part of the integrated delivery system, and each organization has to truly embrace that. Part of that means, so if you have a partner, partners can communicate easily with partners. So we have to make sure that communication between organizations is good. We have to make communication between point of service providers good. So a lot of what we're going to do in this system is build better health information infrastructure. Because truly, if a patient touches our system in one place today and a different place tomorrow, unrelated organizations, except that they're part of the CCC, to the patient, it should seem seamless. When they walk into the second provider, they say, oh, I see you got seen at that other clinic yesterday, and this is what that doctor did. Right. Let me use this information to help provide you even better care as I provide care for you today. And if we don't put that in place, we're not truly partners, we're not truly integrated. And so that's part of the work that we have to do.
George, you want to add something?
I think Mark is exactly correct. There's a unique thing all of us have in our pocketbook or purse, a ATM card that allows you to go anywhere in America and get money out of your bank account, no matter where you are. But we don't have that with the medical record, is what Mark is alluding to. If I travel a lot, if I have a problem, my healthcare records are right here at CommUnityCare in Austin, Texas. But that provider, wherever I go, to Dayton, Ohio, they can't get my medical records here. And that's one of the things we're trying to build in this CCC, which is equally important. So if a patient goes to Seton's ED and they then come to El Buen should be able to have access to that ED records to better take care of that patient. If we don't have that, we don't have true integration.
Well, and I'm very glad y'all brought that up spontaneously, because one of the questions we have from the audience has been, has there been any focus on development of a registration system that can be shared / used by various hospitals to reduce the time, effort, and accuracy of patient information and coverage data? And you're talking generally about that, but
Way beyond that, just as these guys are saying, that's a one step that's annoying to all of us, right? You go to, we were just talking about this morning. You got to fill out those paper forms.
Same thing all over
Paper
again.
forms.
Yeah.
You know, that's the same information. Don't you know where I live?
Yeah, right.
You
But
know,
let me ask a question of the audience real quick. Is how many of you out there work for a healthcare organization? Okay, so fair, 40% maybe. So of those of you who just raised your hands, how many of you know what iCare2 is? So the numbers get real much smaller. So is everybody aware that Travis County has a health information exchange? So Travis County has had a health information exchange. This is not new. We didn't just build this. It's been in play for quite some time. It's actually in its second iteration. And what it does is it collects data from all of the organizations that are involved. Originally, it was in the care of the indigent. Now, and it's still involved in the care of the indigent, but various providers, including Seton Healthcare Family, including St. David's, including all of our clinic providers, including Integral Care, including Volunteer Health Clinic, they share their data into a health information exchange that's available to other providers. And it's a super well-kept secret. I was at the Travis County jails yesterday, touring the healthcare facilities at the jails.
I'm glad you finished that sentence.
I left the jails as well.
Yeah.
I was at the jails. I was meeting with their medical director, and I asked him, "Do you guys have access to iCare, the health information exchange?" And they didn't know what it was. And so by end of business Monday, they'll have connection to the exchange, because I had my data person with me, and we just went ahead and made sure to connect them. Now, does it currently do everything we need it to do for the future? The answer to that is no. It doesn't carry enough data. It doesn't carry it easily enough. There are some failings of it. It doesn't do everything we need it to do, but it's a framework. and it's one we're gonna build on. I think Clay probably has thoughts of how much bigger we need to get.
I've heard him say, and I want him to follow up as soon as.
But it is not that we haven't long thought that we needed better data connectivity in order to facilitate the work that we're doing. And that will be a continuing piece of work that probably never ends, because it probably will always be able to be improved in some way to better facilitate care.
Yeah, I think that it's great that we're as far along as we are. The hardest part of that is the agreement to share data. So just having that is fabulous. But I mean, this I think could be a huge differentiator for us, and it's really required. It's amazing that we would allow our cities to be so complex and not to really understand what the predictors of health are in our cities. So who in the audience knows the #1 killer in Austin in health conditions? There's one, because you generated the data. Interestingly, and this is okay for me to talk about, right? It's cancer. It's not heart disease here. It's cancer. Almost every other city in the U.S., it's cardiovascular disease by far. So somehow we've flipped it, but we don't know why. Why are we cancer #1? And why are we cardiac disease #2? What really are the rates of hypertension in the city? Where are the problems where it exists? Where are the high rates of diabetes? Where are we starting to see diabetes in schools? Can we target those schools? We have efforts. Optimal Children's Health, Children's Optimal Health, I always get that backwards, is one example of an entity that does that. But we really should have this data on an ongoing basis. It's just as important as the economic data for the city. And we got a ton of economic data. We need to understand how health works. A system like this can do that, help with prioritization. It can help in the delivery of care, and then it's absolutely critical in designing health care that we can show has value. So if you've got a great idea and you're going to make this neighborhood healthier, prove it. Right now, you can just say that, and you can do a little survey at the end, and no one really knows whether to trust you or not. If we really want to pay based on results, then we have to have solid data to show results. Currently, we don't have that. So for all those reasons, we've got to do it. I think Austin is actually particularly well set up to be the leader in getting this done for a variety of reasons, but I think we can do it.
George, quickly, and then I want to go to some quick questions as we wrap up this panel.
Just quickly to add on what Clay said is that also in Austin, very affluent, very rich community, very diverse community. 17.1% of the residents are in poverty, below the federal poverty level. And that's something that we certainly need to deal with in dealing with the issue of why we have these diseases. Poverty is a driver of lower healthcare and the disparities. We have some major disparities in healthcare in a lot of areas. I won't quote the statistics now because of time, but I'll do that a little later. Yeah.
So let's run through some questions quickly so as we wrap up, and I keep everybody on time. One question we got from the group, and by the way, if you haven't heard your question specifically asked, I've tried to weave it into some of what we've done here. What area, counties, contribute to the funding of central health, and are the tax rates the same for all? The only county that contributes to central health is Travis County.
Right.
And the only variance, as I understand it, in the tax rate would be if you were a senior and you get that exemption for being a senior. Everybody else pays the same. Question for the entire panel. I'll just let you all free-form it, but know that we're running out of time. And I know who wrote this, and he's not a doctor, but he meets the first requirement of being a doctor because I can't read his handwriting. But and he knew I was going to take a cheap shot at him. What medical uses or services would best be provided on the area of the UMCB campus and maybe as part of the University of Texas property as opposed to elsewhere? And Clay, and I also want to hear Debra's thoughts on that.
Yeah, we haven't really talked about, I think we've got to think about these as not, okay, here's one campus and here's another campus, but really how do we think of them together and make sure the uses that are defined by this group are met in the most appropriate place, whether it happens to be over a historic line that defined it as UT's property
Right.
or a historic line that defined it as Central Health's property. So I think we're starting to do that and come together to talk about it. I think having a major hospital level 1 trauma center there means if we are going to have related activities that require inpatient services, we ought to think about them being adjacent. So that's one critical thing. Medical office space, mostly it belongs in communities where it is easy to access, but for specialty care, that's not going to be possible or feasible, so that then becomes a key need. Incubator space is another one. That really belongs right there and will be useful. And then simulation space is another one we haven't talked about. We all share in having needs for that. It should be centralized. There's several locations that could work, but that's a logical one. So those are a few.
Debra, since y'all are building in the area, what's your thought on it? You're leaving part of the area and going to another part of the area. What's your quick thought on
I
that?
think the biggest thing I would say is echoing the, Clay's idea of the simulation lab. That is space that we already have, and it makes sense that we reach out to other community partners in academia to say, is there one way to centralize this and keep it in that current space instead of recreating it?
I thought it was interesting, by the way, I saw the survey for the first time today, like all y'all did, and I think I remembered this right, 71% of the folks that responded want their health care near them. And what Clay was saying about how there's some things better in the community, but some things you're not going to be able to do. Along those lines, one of the other questions was, how will you be working with other local schools to train and prepare local health staff?
Oh, that's a great question. Yeah. Yeah, so that's another thing that came out of the survey. People want it close to where they work or, where their kids go to school. We have to be thinking about how we raise the game for everyone potentially involved in health. We've tended, when you look at cuts, the school district looks at cuts, and then those school nurses, well, maybe we don't need them anymore, and then they get cut. Well, the impact of that is felt by other parts of our system.
Yes.
So we're not making good decisions. We need to sort of take a societal perspective and reevaluate how we can raise the game and get the appropriate levels of financial support in order to do that.
And one more thing I would say is, in building for healthcare of the future, there's often this emphasis on, well, healthcare professionals train in hospitals. And I'm both a nurse and a physician. I've been through both sets of education, and almost all of that education was inside a hospital. And I spend all my time now dealing with how are we going to practice medicine and nursing outside of a hospital. Most healthcare is provided outside of a hospital, and we need to get out of this mindset that it's all about the hospital and that we're going to put all of that training inside the hospital. We need to be pushing that into the community, where guess what? Most healthcare is provided, most patients are seen. That's where all the action is. That's where we need to begin to press the educational issue as well.
Let's say thank you for this wonderful panel. Thank you all very, very much. I got to tell you, I feel so fortunate that I get to work with these folks and learn from them and see. We live in a very special place, that these are the kind of leaders that we have in healthcare making a difference. And I would be wrong. Yeah, give them another round. Thank you. And as we start moving into the next panel, I would be remiss if I didn't, particularly after we hear how Central Health is so uniquely meeting its mission. I didn't say, as I'm standing here looking right at all the board members of Central Health, God bless you and thank you, and let's give a round of applause for that.